Okay, with that, I'd like to welcome our guest speaker, Louise Bride, Senior Advisor from Stroudwater Associates. Louise Bride joined Stroudwater Associates in 2013 and brings to the firm more than 35 years of experience in healthcare management and clinical operations. She has a proven record of accomplishments in developing and executing initiatives to enhance and improve quality and value of healthcare delivery. At Stroudwater, she focuses on population health, strategic planning, clinical quality and operational improvement, and models of care, including patient-centered medical home and team-based care initiatives. In addition, she co-leads the 6 Building Blocks Opioid Management Program service, offering an evidence-based quality improvement roadmap to help primary care practices implement consistent, guideline-driven care for their chronic pain patients on long-term opioid therapy. We're honored to have you with us today, and I'll now turn it over to you, Louise.
I don't think Molly mentioned the learning objectives, but we hope that you will come away feeling some degree of comfort with identifying and briefly describing the CMS recognized levels of post-acute care services in the United States, and a basic awareness of value-based care models and enrollment trends in the United States, as well as a general understanding of the impact of value-based care and reimbursement arrangements on post-acute care utilization. And I'll touch just a little bit on implications for the future. So that's what we hope to accomplish today, and really appreciate the opportunity to speak with you today. One thing I don't think Molly mentioned, I will add just by way of a little bit of additional information about myself, and that is I do have a clinical nursing background. As Molly mentioned, I've been with the firm now for just a little over 10 years, which is hard for me to believe. And I have had the opportunity to really focus on a range of clinical, operational, and clinical performance actions and activities, as well as models of care, which have really particularly enjoyed, and have some background in post-acute care actually before becoming a Stroudwater consultant. So delighted to have this opportunity to speak with you all about this topic today. So what is value-based care? As you know, traditionally in the United States, healthcare has been delivered and paid for on largely an episodic fee-for-service-based reimbursement approach. And historically, without a lot of focus on quality of care or clinical outcomes, or really any attention historically to the patient's experience of care. And so there's been a very explicit decision in the United States to begin to move away from that traditional fee-for-service reimbursement methodology and to move to value-based reimbursement. And in conjunction with that, typically value-based reimbursement then really changes the focus so that it's away from periodic, episodic, volume-based approach to thinking more comprehensively and thinking in terms of the overall continuity of care as an individual patient or groups of patients move across in and out of the different healthcare settings. And so as you see here from this first bullet, the American Academy of Family Physicians has really described it as moving to comprehensive and continuous, and from their perspective, primary care, and does not really focus on just those individual episodes of care, and also thinks in terms of looking at a more cost-effective approach to care delivery, where quality and outcomes are priorities for attention and focus. As you can see in this next bullet, the goal is really in a value-based payment environment to really hold the providers, physicians, clinical facilities accountable for quality as well as cost of care. typically through some sort of shared financial arrangement that does put the providers at some risk if they do not achieve agreed upon typically clinical quality outcomes or perhaps utilization metrics that have been established and agreed upon. As you can see in the comments from the Commonwealth Fund that they think in terms of value-based care, tying the amount that healthcare providers earn for their services rendered to the results of the care that they are delivering. And interestingly, because it has become such an area of focus really over the last couple of years in particular, they have talked not only in terms of quality of care and cost, but also equity, which is a newer area of focus for sure. And then finally, a quote here from the Commonwealth Fund that value-based care programs aim to hold providers accountable for improving outcomes while also giving the providers and the healthcare clinical teams greater flexibility in the way in which they are delivering the care, the goal being the right care at the right time in the right setting. A few key terms, and I've actually already utilized several of those just in these opening remarks. For those of you who may not have a lot of experience in the value-based care and value-based reimbursement environment, a few of the really common terms that I will refer to and that you will see over and over again in the literature, in articles that are talking in terms of value-based care. And that is, again, designing care so that it focuses on quality as well as provider performance, and then looking at patient outcomes and the patient experience of care. Alternative payment models are really just what those words say. So moving away from that traditional fee-for-service reimbursement for a fee for a specific service rendered, and moving to other ways of organizing and paying for healthcare. An alternative payment model may be focused on a particular disease or health condition, and end-stage renal disease has been one of the earliest applications of an alternative payment model addressing the care of patients with end-stage renal disease. It may be a care episode. Joint replacements were a big area of focus a few years ago as an example. It can be at the community level. The Pennsylvania Rural Health Model will be an example of that. And I'll talk a little bit later on about accountable care organizations, and also we'll talk about the Medicare Advantage plans, which would clearly look at alternative ways of reimbursing providers for care and services delivered. Capitation is a very common way in which, alternative to fee-for-service, a way in which providers are reimbursed, in which the payer or the providers, the organization receives a predictable, agreed upon set amount of money up front, typically, to cover an agreed upon set of healthcare services. And so, and that would be, the example of that would be the Medicare Advantage plans, where they receive a set amount of money on a per member, per month basis, in turn for which they are then responsible for delivering or arranging and coordinating and paying for Medicare covered services. I've already used the term ACO. An ACO organization, an accountable care organization, is essentially a group of doctors, hospitals, other healthcare professionals, other healthcare organizations, including, it could be a home health agency, or more particularly a skilled nursing facility, could be a member of an accountable care organization who come together, form an organization, receive reimbursement for providing care and services to the group of patients who become associated with that ACO, and are then responsible for providing, typically the goal again around high quality, coordinated, comprehensive care with the goal of improving health outcomes as well as managing costs. And we will talk we will talk a bit more in a few moments around the Medicare Shared Savings Program, which is an example of a large and national ACO. Shifting gears now to talk about the other part of this presentation, and that is looking at the move to value-based reimbursement, to move to these alternative reimbursement arrangements, specifically in the context of post-acute care. So what do we mean when we talk about post-acute care? The Centers for Medicare and Medicaid Services for quite a long time now they have identified and recognized 4 specific levels or settings of post-acute care, and you see those listed here. So you have the inpatient rehab facility setting. For those of you who may not be so familiar with the IRF facility setting, that is an entity that provides intensive inpatient rehab services, typically physical therapy, occupational therapy, speech therapy. There are specific requirements for an entity to be approved as an inpatient rehab facility. One is that there are 13 conditions, specific conditions that have been defined, and that entity has to treat some, if not all, of those 13 conditions as a major element of their patient population, and the patient must be able to demonstrate and benefit from, and be able to tolerate intensive 3 hours of therapy services per day to really meet the criteria for inpatient rehab facility setting of care. The second is the long-term care, the LTAC. There are a couple, I've seen probably 3 different iterations of this name. You see 2 here, long-term acute care and long-term care hospital are 2 of the commonly used acronyms for this level of care. Again, there are some specific criteria. This setting is really focusing on serving long-term, chronically, critically ill patients, typically that would have maybe multi-system failures, and in particular, respiratory failure can be very common for this patient population. And there is a requirement that there is an average length of stay of greater than 25 days for qualifying cases. Skilled nursing facilities would be well known, I'm sure, to all of you, and in fact, many hospital systems across the country own and have an affiliation with one or more skilled nursing facilities in their community to provide short-term skilled rehab services, and then you also would have entities that are providing long-term, essentially custodial care. For this purpose, this is really focusing on short-term skilled care for individuals who have had a minimum of a prior 3-day inpatient hospital stay to be eligible to then go to a skilled nursing facility for skilled rehab services. And then lastly, home health agencies, which are providing healthcare services to individuals who are in their home setting but require additional supportive medical and therapy services. Hospice services, interestingly, may also be included in discussions about post-acute care. The MedPAC, and I'll talk a little bit about that commission, includes hospice in their reports and in their meetings, but it's not listed by CMS as one of the official 4 settings of post-acute care. So hospice kind of is sometimes in and sometimes not included. The next couple of slides, I wanted to take a quick look at a snapshot of the total number of post-acute care providers that are recognized in the United States, and this is looking at a period of from 2017 through 2022, so pretty current data. This does come from MedPAC, and they particularly were paying attention to the changes in the period, the recent period of 2021 to 2022. And so you can see here, and this is probably not a surprise to any of you all, that skilled nursing facilities, the largest number of post-acute care providers are skilled nursing facilities, followed by home health agencies in the United States, many fewer inpatient rehab facilities, and a much smaller number of those long-term care hospital facilities. So this will give you a sense of the total numbers of providers by those 4 provider types, or those 4 settings of post-acute care. Again, this is coming from very recent, last summer's MedPAC data book, and this is looking at the total spending. As you would expect, it's a very significant amount of money when you think in the aggregate at the national level. And this is looking, again, they have, I didn't show the chart from the book for this particular picture from this particular perspective, looking at the spending trends, because it was a pretty, frankly, confusing and kind of busy chart or graph. But I thought that some of the information would be interesting and useful to you, and that is looking at the period year over year from 2015 to 2021, again, across all 4 of those major post-acute care sectors, looking at total dollars that Medicare spent on a fee-for-service basis. This is looking at just fee-for-service now, setting aside those alternative payment arrangement settings, has seen a decrease year over year from a little over $60 billion in 2015 to 56.8, so almost $57 billion in 2021. In part, that decline, because again, this was looking specifically at fee-for-service spending, the decline was due to expanded enrollment in Medicare Advantage, which would be in a capitated arrangement as opposed to the traditional fee-for-service arrangement. There was a small decline in spending for skilled nursing care due to reduced volume in 2021, and the spending was relatively flat or stable for home health care and long-term care hospitals. Interestingly, and I haven't found really any, in looking at all the various reports and materials, I haven't really found an explanation of why this is true, but in that same period, there was a slight increase actually in spending for the inpatient rehabilitation facility setting. Okay, these next couple of slides are just a summary of a number of actions that have been taken nationally over the last 10 years to reform post-acute care. So these would be initiatives taken by Congress, at the national level, and over that 10-year period has really addressed all 4 settings of post-acute care. We won't go through all of this in the interest of time, but I did want to call out just a couple of things. That last bullet, talking about mandates by Congress, in particular, wanted to mention the last sub-bullet talking about the IMPACT Act, Improving Medicare Post-Acute Care Transformation Act. It's quite interesting to see that they, at the time that they passed that, which was back in 2014, so now quite some time ago, 10 years ago, they had set a goal to have, by last year, by 2023, a common combined prospective payment system that would encompass all 4 post-acute care settings. That obviously has not happened, although work is ongoing to continue to fully implement the IMPACT Act. The Act also did call out and has been true with activity across all four sectors, a focus on quality and on data collection and reporting of performance data to really get at the quality side of the delivery of post-acute care services, as well as focusing obviously on the payment system. So more to come over the future months and years around that goal 10 years ago and moving to one combined prospective payment system that would go across all four settings. Right now, every setting has its own set of rules and regulations and methodologies around reimbursement. You see here also some very explicit language, particularly looking at the SNF, the Skilled Nursing Facility Payment System. You see called out the goal to move, explicitly called out here, to move again away from that traditional methodology of reimbursing based on volume of services provided, and here moving to paying for services based on patient medical complexity and functional level for the specific for the Skilled Nursing Facility Payment System specifically. And you can see that MedPAC established two claims-based outcome measures, looking at average risk-adjusted rates of patient discharge to the community, as well as looking at potentially preventable hospital readmission following discharge. And I had not known this until I delved into some of these more recent MedPAC reports, but and I was actually pleased to see that in addition to looking at quality outcomes measures and methodologies and looking extensively at all the financing mechanisms and total costs of post-acute care, they also, at least here recently, MedPAC has also reviewed skilled nursing facility staffing. And as you can see in 2022, very substantial staff turnover rates were experienced in skilled nursing facilities at 53% for the median 12-month turnover rate. That information came out of a very recent meeting of MedPAC at the year end of December 2023. So I'd like to shift focus now just a little bit and talk specifically about two different value-based purchasing programs. This one is taking a look at the Skilled Nursing Facility Value-Based Purchasing Program. It is a CMS program. And again, you see that move to award to provide incentive payments to encourage quality improvement. Again, that whole idea of moving away from just counting episodes of care and reimbursing based on volume, but now putting an awards incentive in place that will look specifically, it does look specifically at one measure, which is all-cause, the skilled nursing facility's 30-day all-cause readmission measure. And there, that measure, that is calculated for all the skilled nursing facilities that are participating in the skilled nursing facility value-based purchasing program. Again, it's a CMS program. There is risk adjustment done, which means that they will look at variable patient demographics, comorbidities, and other health status variables. With in a risk-adjusted approach, you want to hold those constant so that then you're comparing apples to apples as you look across all of your participating skilled facility providers in determining then who's doing the best in terms of achieving a reduction in that unplanned all-cause hospital readmission activity. So the specific measure then is looking at and counting any hospital readmissions that occur within 30 days of discharge from a prior hospitalization and with an unplanned discharge. An unplanned admission back to the hospital. There is some specific, there's a specific methodology as to how this program, how the payments are handled. CMS withholds 2% of the skilled nursing facilities Medicare Part A payments to fund the program, and then they redistribute 60% of those funds out to the skilled nursing facilities who have done, who have the best results at avoiding those hospital readmissions. And then the balance, that 40% is retained in the Medicare Trust Fund. And I'm going to leave it at that. There's obviously more complicated information related to their the actual payment, payout structure for that value-based program. But suffice it to say, we'll not go into that today, but just know that it is intended to create a positive incentive for skilled nursing facilities to put processes in place to avoid readmissions of their patients, of their Medicare patients. There's also a home health value-based purchasing model. The HHVBP model, it was initially begun on a small scale and ran from January 1st of 2016 through December 31st of 2021. And as you see here, that original model operated only in 9 states, and all the other states continued business as usual. The goals, again, were to support greater quality and efficiency of care among Medicare certified home health agencies across the nation. But again, started out operating this value-based model, this value-based purchasing model, only in 9 states. The results were found to be very positive, and I'll say more about that in just a moment. And that has led to a decision to expand this home health value-based purchasing model to the rest of the country. And so it is now effective as of the end of 2022. This expanded model is now in place across the country. As you see, CMS did contract with an outside party to assist with administering this program. And excuse me, I've got an incoming call here that I need to move. And so ABT has formed, for purposes of this now expanded national in scope program, has created a technical expert panel to provide expertise to CMS around really now fully and effectively implementing this on a national basis, looking specifically at some of the quality elements, the quality factors, scoring methodology, and then exploring whether there might be potential new areas for focus. And again, you see now, as we did earlier on an earlier slide, a focus on not just access, not just quality of care, but now for the first time, also incorporating explicit goals around reducing inequities around access to care, specifically post-acute care. So that's, in a nutshell, just a little bit of information about the skilled nursing facility value-based purchasing program, CMS program, as well as the home health value-based purchasing model. And since it has just been expanded, much more to come in the months and years ahead around the home health value-based model in particular. There is a report that has come out with results from the original model. And again, significant savings were demonstrated for Medicare. As you can see, just under $1.4 billion, $1.38 billion in cumulative Medicare savings across those 9 participating states, which was almost a 2% greater decline in comparison to the 41 non value-based purchasing program participating states. And as you can see, there were declines in most aspects of utilization by fee-for-service Medicare patients. So reduction in unplanned hospitalizations and skilled nursing facility use. Interestingly, there was an unintended increase in corresponding increase in outpatient emergency department visits. So I'm sure that will be a specific area of focus of Medicare's going forward, because an overall goal of all of these value-based reimbursement arrangements and models is to reduce costs, as well as focus on improving quality overall. There was a one quality metric that has shown that did show gain in the 6 years of this initial home health value-based purchasing model, and that was around gains in the participating patient's functional status, around patient mobility and self-care. So again, not only looking at the cost considerations, but looking at the clinical quality results as well. And again, you see some reference. This first 6 years did not show any improvements in addressing existing racial ethnic inequalities around the use of lower quality agencies, and also did not show any change in access to home health. So again, I expect that we will see some additional focus on those elements going forward. A little bit more detail on this slide when you look at the drill down of the spending reductions that were realized during that original home health value-based purchasing model, and that's showing you here the impact for skilled nursing facility services, a 3.9% reduction, inpatient hospitalizations, and home health spending. And that, as we've already mentioned, was offset by a sizable increase, a 6% increase in outpatient ED and observation state spending. Again, likely to be an area of focus of MedPACs going forward. Okay, I'd like to now talk a little bit about the Medicare Shared Savings Program. I had mentioned that a moment ago, and I'm going to actually pull my resource here. Because I'm going to go back to the terms, the sheet of that slide that had some of the common terms when you're in a when you're talking about value-based reimbursement. And one of those is the development and the growth in the accountable care organization model. And just a reminder, an accountable care organization is a group of doctors, hospitals, and other healthcare providers, including skilled nursing facilities, as you see here, who come together and are organized to collaborate and to provide comprehensive coordinated care to a defined group of patients. And in this case, we're talking about the Medicare population. And so this is a very large ACO. In fact, it's the largest in the country. And as you can see, approximately 2,000 nursing homes are participating in Medicare Shared Savings Program ACOs, but that really represents a fraction of the total number of nursing facilities nationwide. So there is recognition of the need for and the opportunity to attract and bring in many more skilled nursing facilities to be participants in the future in the Medicare Shared Savings Program. That program has continued to grow. As you see here, 480 ACOs are participating for this year in 2024. That is an increase year over year. And interestingly, and until I really was delving into this, I had not seen this statistic recently, and that is that now nearly half of fee-for-service Medicare beneficiaries are now enrolled in an ACO arrangement. So again, moving away from that classic traditional fee-for-service world, and now are enrolled in a Medicare Shared Savings Program ACO. One of the things that was, I've saw over and over again as I was looking at articles talking about kind of what's happening, what has been happening in recent years around Medicare in particular as it relates to post-acute care, and that is that by 2030, CMS aims to have all Medicare beneficiaries and most Medicaid beneficiaries enrolled in some type of accountable value-based care program. So that was to me kind of an amazing goal to see. And as I say, I've seen that now over and over again in reports and in articles talking about the goals of CMS around managing this patient population, better managing from the standpoint of both cost and quality. One of the other things that I should mention, and that is, actually I'm going to hop back a slide. One of the things I wanted to mention around this idea of trying to increase the total number of nursing homes participating in ACOs, there are recognized pretty significant barriers to nursing homes participating in the Medicare Shared Savings Program currently. And that, again, it really has to do with the differences in the reimbursement methodologies for skilled nursing facilities versus hospitals, primary care providers. And a group of folks from the American Healthcare Association, which is the national organization that represents long-term care and post-acute care companies, and the National Association of ACOs, representatives from those two national organizations have come together to talk about this very issue of what might be able to be done to create a better environment for more nursing homes to join in and participate in Medicare Shared Savings Programs. Because for an ACO, if an individual member is enrolled in that ACO is then responsible for managing the care and the cost of care for that individual, regardless of whether they go into a skilled nursing facility or not. But if they're in a skilled nursing facility, then it's much more difficult for the ACO to actually manage and impact the delivery of care to that individual. So those two groups are now in dialogue and looking at ways they might be able to advocate for some restructuring of the reimbursement mechanism so that it would be more realistic, more feasible for nursing homes to participate. So we shall see what the future holds, but that is a specific goal of those two organizations, is to find ways to increase the involvement of nursing homes in the Medicare Shared Savings Program. And it is a very explicit goal of CMS to continue to expand the number of Medicare beneficiaries who are in a Medicare Shared Savings Program arrangement. Okay, and now we're going to take a look at Medicare Advantage plans. I mentioned that is yet another model, and essentially in a Medicare Advantage plan, it's a private health plan that has contracted to offer Medicare Parts A and B benefits, all Medicare covered services basically in Parts A and B, and typically also offer Part D, the pharmacy prescription drug benefits. And so Medicare Advantage plans have also grown over recent years. There was some very interesting discussion in the December of 2023 MedPAC meeting record around the growth of the number of Medicare beneficiaries participating in Medicare Advantage plans. And as you see here, commentary that Medicare Advantage plans have become, quote unquote, tougher at managing the utilization cost per day of their members who are in a skilled nursing facility setting. So again, recognizing that the underlying party responsible for the delivery of the care and receiving the Medicare reimbursement may not actually be directly caring for that individual, or certainly not as fully as they would otherwise if that individual is now in a skilled nursing facility setting. And so the commentary went on to say that one party indicated half of the skilled nursing facilities, skilled business, are individuals who are now members of a Medicare Advantage plan, including large national Medicare Advantage plans with a lot of leverage. And so it was surprising to me to learn that as of 2023, so last year, 52% of beneficiaries were enrolled in a Medicare Advantage plan. So that's a sizable percentage of the total Medicare population that are now actually in a Medicare Advantage plan. There are findings. There's information in the literature, and in fact, a report explicitly, a fact sheet put out just a few years ago by the American Hospital Association that does discuss the impact of Medicare Advantage plan membership on some of the post-acute care settings of care. The Hospital Association explicitly calls out the impact on inpatient rehab facilities and long-term care hospitals. Again, those are two of the four official post-acute care recognized settings and types of facilities for post-acute care. And that to the extent that some Medicare Advantages exclude those types of entities in their network, that does limit access to those levels of care for those participating Medicare members, those Medicare patients or beneficiaries. Interestingly, there have been a flurry of articles very recently in Modern Healthcare indicating that home healthcare companies are really kind of feeling the squeeze, so to speak, because to the extent that they are now caring for individuals who are enrolled in a Medicare Advantage plan, the Medicare Advantage plan is who now pays the skilled nursing facility or pays the home health care agency. And so there are competing goals there, because the home health agencies obviously want to maximize the reimbursement that they are able to receive, and the Medicare Advantage plan, because they are in a capitated arrangement, they receive that fixed amount of money on a per member per month basis for those Medicare covered individuals who have joined their Medicare Advantage plan. So the Medicare Advantage plan's goal is to reduce utilization and to control costs, and the home health agency obviously wants to increase their access to provide services to those individuals. So the greater the numbers of Medicare beneficiaries who now enroll or are enrolled in Medicare Advantage, the greater the potential impact on these settings of post-acute care. One healthcare analyst estimated that home health companies are making substantially less in terms of reimbursement from Medicare Advantage plans as opposed to traditional fee-for-service Medicare. So that creates obviously a financial risk, a financial threat to home health agencies. Another threat is that some of the large national health insurance companies who offer Medicare Advantage plans have now either purchased, well, generally they have purchased a home health care company to have as part of their network, that thus essentially, kind of squeezing out other home health companies or healthcare companies that are in their service area, because they are referring their members to their now the home health companies that they now own. And a couple of big companies were explicitly mentioned around who have taken that step and have now have acquired their own home health businesses. United Health Group and Humana explicitly were mentioned. So that will be a trend to continue to pay attention to as well. That will directly impact then other home healthcare companies in local communities. That brings me to the end. This slide lists a number of other links. As you may have noticed as I was going through the slides, I had put in a lot of links to the sources for the information that I have shared in those slides. But I also, in the course of preparing for today, just found some other good articles that I didn't directly pull from necessarily, that I thought might be of interest to you or be useful resources for you. So you see them listed here, and I think it's actually on one or two of those slides previously, but I did want to include for you that link to the July of 2023 MedPAC data book. I have just pulled out some snippets of information for you from that data book, but there's a wealth of other information there and wanted that to be available to you as well. And that brings me to the question and discussion point in my presentation today. So Molly, I'll turn it back to you and see if you've received any questions so far in the chat box, and otherwise we certainly can open it up to the audience.
Yeah, thank you, Louise. That was very, very informative. We appreciate it. I'm not seeing any questions in the chat box, so if anyone wants to come off mute and ask, feel free.
Well, while we're waiting, let me mention one other thing that I don't think I mentioned a moment ago in talking about the Medicare Advantage plan. One of the potential real benefits to the Medicare beneficiaries who choose to enroll in a Medicare Advantage plan is that, in addition to covering, providing, arranging for, and paying for the full set of Medicare covered services, frequently Medicare Advantage plans add additional benefits that are not standard Medicare covered benefits. And good examples of that would include dental services, vision care, maybe hearing. All are services that are obviously often utilized and needed and valuable to the Medicare beneficiary population. And so that's become quite common, is that Medicare Advantage plans have the prerogative of expanding that they must provide or pay for all Medicare covered, fee-for-service Medicare covered services, but have the opportunity to add to that. And as I say, that's quite common now. And so those would be other reasons that would incentivize Medicare beneficiaries to choose to enroll in a Medicare Advantage plan, as opposed to staying in fee-for-service environment or going in or being in the Medicare Shared Savings ACO, as an example, where we would still be, basically accessing the Medicare covered services. So I did want to mention that. Some examples of organizations that have done that have now, that offer expanded benefits are United Healthcare's Medicare Advantage plans, Kaiser Permanente, Humana, Aetna, Cigna. They were all named as large, well-known and national health plans who are now offering Medicare Advantage plans and do have expanded benefits. Any questions, any comments? I would certainly welcome any comments as well. If this was helpful, if this has triggered other kind of other thoughts about areas that you're interested in further delving into as it relates to that intersection of value-based care and post-acute care service delivery.
Yeah, no questions in the chat. A couple of comments. One from Brad Gibbons, who was mentioning he didn't know there was that level of activity for NH and home health and value-based care. So much focus on hospitals and PC clinics, but other parts of healthcare are involved too. And a good link from Carla in the chat too, if anyone wants to copy that for reference.
Well, just kind of following, I didn't realize the nursing home, I didn't realize home health. What, if anything, do we know about where public health is in terms of value-based care. That's kind of a bugaboo issue that I've been trying to mull over, and we've been talking a little bit about in North Dakota. It just seems so intuitive that the focus of public health seems to fit very nicely in a value-based care system, but I don't know how the money would flow, so to speak.
Yeah, that's a really great question. And I have to say, and that your question is stirring me. I'm going to have to go do some homework on that, because I actually do not know. I have, I don't know that I have seen anything in the, in the healthcare journals. I'm sure there must be something out there. I have not really seen anything that addresses that component when you think about the total healthcare delivery system in this country. So I actually do not know. I do not have any recent information about what has happened with that. The only thing that I would say is, since public health, there's a state, there's typically, I think the structures clearly vary state to state, but that's, kind of under the umbrella of state government. In any given state, as a department of the state's governmental infrastructure. And so I don't know. I do know that for Medicaid nationally, and of course Medicaid, unlike Medicare, the classic saying is, if you've seen one Medicaid program, you've seen one Medicaid program, because there's so much variation across the country. But there has been a very substantial trend to moving for state agencies, to Medicaid agencies, to contract with value-based companies, with Medicare, with managed care companies, to move into the same kind of arrangements that Medicare has through the Medicare Advantage plan and the MSSP program, around states contracting with companies to assume responsibility to deliver the Medicaid covered services to defined, at least some of the defined Medicaid patient populations. Because again, there are a number of different subpopulations under the umbrella of Medicaid typically. So that whole idea of managed care, paying a capitated arrangement, has heavily moved into the state Medicaid programs, but I really have not seen anything that talks about public health specifically.
Well, if you look
That's
at, if you find out anything, definitely, I think a lot of people, certainly in North Dakota, is interested. Thanks to our very good friends and colleagues in terms of rural health value, and also the National Rural Health Center in Duluth. We have two different efforts happening, or have been happening, in North Dakota relative to value-based care and getting our cause involved. And actually, 65% of our cause are in a clinically integrated network that's now linked in with an ACO. And we have one CAW that is working very closely with their local public health. They're engaged on a dementia program, and CAW that's in this ACO. So that's where you start going, okay, for me, from an ethical perspective, if you're a hospital and you reach out to other groups who are going to help you be accountable for the quality of care for that patient and lowering the costs, there has to be a way to share some of the benefit, covering contracting costs. I don't know, but that goes beyond my knowledge base. But I just think public health can be a real critical player.
I think that is a really great comment, and what you've just described is so consistent with the challenges around increasing the participation in these arrangements of the skilled nursing facilities. Same kinds of reasons, just the incentives, the reimbursement methodologies, they just don't align, and so there are some real fundamental areas of focus that certainly CMS is going to have to continue to grapple with to meet their goal of having everybody in a value-based reimbursement arrangement by 2030.
Thank you. Appreciate it.
Yeah, great question. Thank you. Kathleen, I saw you nodding your head a few moments ago. Any any thoughts or comments that you would like to throw it out here for the good of the group?
Oh, thanks, Louise. Yeah, what you had said rang true for me, that in Massachusetts, that we have our Medicaid ACO program really has made, over the last few years, has made use of local community-based organizations or our local public health to provide, outreach services, education services, case management services, those linkages kind of services that have really, that I really do think help support the better health outcomes. But yeah, we haven't been able to do the same on the Medicare side, that's for sure, or with long-term care at all. And, Massachusetts, I think they're still pretty separated from community-based organizations, unfortunately, in that way. But it would be nice if from the federal level that more of that kind of an approach got supported through the Medicare program as well as the Medicaid program.
I think that's right. Yes, I have some familiarity and actually have done some consulting work with organizations in the Mass participating in the Mass Health program. And you're right. I think their goals, Massachusetts goals, clearly are very similar to some of what I described today around Medicare, around trying to create a structure and create models that do support a focus on not just quantity, but particularly, setting very specific quality and outcome goals and tying reimbursement to that. So yeah, absolutely. Well, thank you, everyone. I've appreciated your attention, and if you do think of other questions, do not hesitate to send me an email. I don't think I showed it, but the last slide, I think I didn't show it, but the last slide should give you my contact information, and certainly don't hesitate to reach out to me if you have questions or if you need me to resend a link to one of the resource materials that I've referenced throughout. I'm more than happy to do that. And I hope this has been helpful. Thank you for participating today.
Thank you, Louise, for a very informative presentation. Thank you, everyone, for your participation. If you could answer those polling questions before you jump off. As a reminder, today's recording and slides will be available on the RIPT website within about 5 business days. As always, we encourage you to reach out to us at RIPT if you have any questions. Thank you again, everyone, for your participation, and have a great rest of your day.